name is Caleb, and I'm a second year pharmacy student.
My name is Samantha Dolan. I'm a physical therapy student, and we're going to present our patient WS to you today.
As we were getting ready to delve into this exercise, we found it relevant to ask ourselves why it is important to have an interprofessional approach in patient management. The Institute of Medicine Committee on Quality of Healthcare in America uh, pointed out that healthcare professionals working in interprofessional teams can best communicate and address complex and challenging needs. The IOM further points out that this approach allows sharing of expertise and perspectives while forming a common goal of restoring and maintaining an individual's health and improving outcomes while combining resources. And our two disciplines, pharmacy and physical therapy, share common values and interests in patient welfare and patient well-being. Our patient WS is a 79-year-old female, and she suffers from multiple comorbid disease states, the main one being hypertension. Uh, the other disease states include hyperlipidemia, depression, anxiety, bipolar disorder.
She also had a stroke 22 years ago, and she also had a pacemaker about 22 years ago as well. She lives with her husband and children and grandchildren. She's retired currently, and she has a sedentary lifestyle.
WS has no known drug allergies, and in her home currently there are 4 stairs to enter with a railing on the left side, and inside there are 6 stairs to get to her bedroom with a railing on the right side. WS utilizes a straight cane for household ambulation and requires a manual wheelchair for long distances. She has not in the last year experienced any falls.
And these are the medications that she is currently taking. Levothyroxine 0.05 milligram, one tablet per day, and Nadolol, which is a beta blocker, 20 milligrams per day. Uh, and she's also taking citalopram, 20 milligrams a day as well. And she's also on simvastatin, which is a statin, and it's a 20 milligram tablet per day. And she's also on Seroquel, which is 25 milligram tablets per day. And she's also taking Benadryl, PRN for allergies, and she's also taking vitamin D and vitamin C tablets.
WS is able to ambulate with a straight cane for about 50 feet before requiring a rest. Her husband reports that she has difficulty performing sit-to-stand activities. WS reports pain in her bilateral knees after performing any activity. WS's husband reports that she lives a fairly sedentary lifestyle and that she requires min assist of 1 for toileting and bathing, but she can perform all other activities of daily living independently.
WS's primary problem, according to our prioritization, is her stroke, and hypertension is one of the major treatable risk factors for stroke. We think it is important to avert the likelihood of another stroke, as it would have devastating consequences on her prognosis.
Okay, now we are going to talk about some subjective information regarding our patient. Our patient WS reported feeling fine on the day of the interview. Uh, the patient's husband reported that the patient is frequently forgetful and easily agitated. The patient's husband also reported that the patient often complains of pain in bilateral knees after an activity, and he also reported that he would like to know if there are other things that they might do in order to help them with the lingering side effects of the stroke. Finally, he also told us that he is unable to get quantitative assessment of pain because the patient was unable to answer some questions.
This is some of the objective information that we were able to gather about WS. Unfortunately, there was no physical examination performed because the information was only gathered via a telephone interview, and the husband was unable to provide any anthropometric data, and he did not know the patient's last blood pressure or heart rate measurements from her last physical examination. We did know that WS was confused on the phone, and she was unable to answer any of the interview questions, and she did allow her husband to answer the questions for her via the telephone call.
Okay, now I'm going to talk about an assessment of WS's conditions from a pharmaceutical standpoint. Um, WS's hypertension is not adequately controlled in line with evidence-based treatment guidelines. Most evidence about the effects of blood pressure on the risks of cardiovascular disease derives from two principal sources. One is prospective, non-randomized observational studies of the association between blood pressure and the incidence of stroke, and the other is randomized trials of antihypertensive drug therapy. Um, Analyzing when we are analyzing her medications and her disease states, we found out that there is an adverse drug event where citalopram, one of the drugs that she takes, which is citalopram, has a very significant drug-drug interaction with the Seroquel that she's taking. Um, and we also found out that the nadolol, which is the beta blocker, is an ineffective medication in her case, and there is some other medication that she can take, like ACE inhibitors or uh, angiotensin receptor blockers, which can greatly reduce her hypertension. And we also found out that the Benadryl that she's taking is unnecessary and it doesn't have any indication. And apart from that, the Benadryl that she's taking and the Seroquel have significant drug interactions as well. And again, the Benadryl and the citalopram that she's taking has additional drug interactions, which all add up to the problems that the patient might experience from an unnecessary medication, unnecessary medication therapy. Um, we also found out that the itself has big contraindications in adult patients. So we are considering revising these medications through consultation with her physician.
This is the physical therapy assessment made for WS after gathering all of her information. WS is a 79-year-old female with past medical history of CVA. She has a pacemaker, she has hypertension and hyperlipidemia. WS has decreased cardiovascular endurance secondary to her past medical history and her sedentary lifestyle. This decreased endurance has limited her ability to perform some of her activities of daily living, such as toileting and bathing, and has limited her ability to ambulate for long distances. WS would benefit from a physical therapy program for cardiovascular endurance and strengthening to improve her ability to perform these ADLs independently without becoming fatigued. However, WS's prognosis is poor secondary to her cognitive deficits that may decrease her ability to perform these exercises safely at home. She's a patient that might require more supervision in order to safely perform an exercise program.
Now I'm going to talk about the pharmacological plan that we have in place for WS. The first part of our plan is to schedule an appointment with Dr. Falango to discuss the optimization of WS's antihypertensive medications. And our recommendations would be giving her an S inhibitor with a beta blocker, or an angiotensin receptor blocker with a beta blocker. And there is a profound argument for providing these medications in a patient like WS who has multiple comorbid disease states. Um, the second part of our plan is to discuss the potential benefit of initiating new therapy as well as optimization of WS's current drug therapies with regard to depression, bipolar disorder, and knee pain. The third part of our plan consists of providing patient education about the importance of activity or physical exercise in improving cardiovascular health. And the fourth and the final part of our plan would be to provide education to WAS's husband about exercises that she can do at home with his supervision. And our justification for the drug therapies or the plans that we provided emanate mainly from the evidence-based guidelines that we found on Dynamite. Um, Dynamite suggests that for patients like who have coronary artery disease or high risk of cardiovascular disease, a thiazide a beta blocker, or an ACE inhibitor, as well as a calcium channel blocker, helps to alleviate her conditions. Dynamite also details that stroke or patients who have had stroke or transient ischemic attack before can greatly benefit from a thiazide diuretic or an ACE inhibitor or a calcium channel blocker.
We also would like to warn WS as well as her husband that there are specific warning signs that are associated with an impending stroke attack, and in the event that one of them witness these warning signs, uh, we will recommend that they call 911 right away.
In summary, WS is a 79-year-old female with a significant past medical history of CVA, a pacemaker, hypertension, and hyperlipidemia. Her chief complaint is her increased fatigue with activity that limits her ability to perform her activities of daily living. WS would benefit from physical therapy to improve her cardiovascular endurance and the initiation of a new pharmacotherapy program to address her hypertension according to evidence-based guidelines. Some barriers to progress for WS are her confusion and agitation, and these may limit her ability to make strides even if she follows both of these new programs.
Jenny and her grandma May on an ordinary day. When they're in the kitchen, Grandma started to sway. Grandma sounded strange when she spoke, and Jenny had to ask, what if my grandma's having a stroke? I think I better act fast. I think I better act fast. Does her face look a little bit uneven? Does one arm drift down? Is her speech coming out kind of strangely? Then it's time to call 911. Jack and his favorite friends were having lunch in town. When Hank looked up, half his face drooped down. Hank wasn't making a joke, and so Jack had to ask, what if my buddy's having a stroke? I think I better act fast. I think I better act fast. Does his face look a little bit uneven? Does one arm drift down? Is his speech coming out kind of strangely? Then it's time